So we are going to start with acute morphine poisoning after discussing the common physiological and pharmacological effects of the morphine. So what will happen? So acute morphine poisoning, the symptoms will be exaggeration of the effect produced by the normal dose. So what is the dose which can create the problem? In the non-tolerant adult, 50 mg morphine IM produces serious toxicity. Why I have mentioned the non-tolerant adult? Because the patient or the persons who are taking the drug chronically, for them higher dose is required to produce toxicity because morphine causes significant tolerance. So in tolerant subject, dose is higher, but in non-tolerant subject who are not taking the drug, 50 mg is often causing serious toxicity. And human lethal dose is about 250 mg, be it tolerant or intolerant patient, non-tolerant patient. Okay. So the human lethal dose is about 250 mg. What are the manifestations? Stupor or coma, flaccidity, shallow breathing, cyanosis, pinpoint pupil, fall in BP and shock, convulsion. This pinpoint pupil is very characteristic of the morphine poisoning. In what other poisoning we can find pinpoint pupil? Organ phosphorus poisoning. So shallow and occasional breathing, cyanosis, pinpoint pupil, fall in BP and shock and convulsion. These are the adverse manifestations of the acute morphine poisoning. And death is mostly due to respiratory failure due to CO2 retention. Now, what is the treatment of acute poisoning? Positive pressure respiration to remove the excess CO2 which is retained. Maintenance of the blood pressure. IV fluid vasoconstrictor are given because in morphine, as it depresses the vasomotor center, there is significant drop in the blood pressure. So you have to elevate the blood pressure in acute poisoning. Gastric lavage should be done with potassium permanganate to prevent the further absorption of the drug, and lavage is indicated even when morphine has been injected or given in IV or IM route. So this is a very unique thing, but it is very commonly asked in examination. So why gastric lavage is needed in acute morphine poisoning even if morphine is not ingested? Even if morphine is given by IM or IV route, still lavage is indicated. Why? Because once again we have to go back to the general pharmacology. So morphine is a basic drug. So when morphine after IV or IM administration is comes to the systemic circulation, and when it traverses through the stomach, in the stomach there is some secretion of the morphine from the blood vessel into the stomach, and in the gastric medium, which is acidic in nature, there this morphine, which is being a basic drug, it becomes ionized. So it is ionized in the gastric lumen, and from there it is not absorbed in the stomach. But this not absorbed morphine, ultimately when it reaches to the intestine, there in the basic medium there is once again this ionized morphine are non-ionized, and from their intestine it is again absorbed. So there is chance of recurrent toxicity if stomach gastric lavage is not done. That's why gastric lavage is indicated when morphine has been injected. So being a basic drug, it is partitioned to the acid gastric juice, ionizes there and does not diffuse back into the blood. So from stomach it is do not diffuse back into the blood, but this non-absorbed morphine when reaches to the small intestine, they are in the basic medium, they are non-ionized and better absorbed. So there is chance of recurrent toxicity. That's why gastric lavage is needed, whatever be the route of the administration of the morphine. What is the specific antidote in acute poisoning? We can give naloxone 0.4 to 0.8 mg IV repeated every 2 to 3 minutes till respiration is normalized. Does not have any agonistic action. So naloxone is a non-selective opioid antagonist, but predominantly acts on the mu receptor. It does not depress respiration. It has a short duration of action and very quick onset of action. Injection should be repeated every 1 to 4 hours according to the response. So what is the precaution and contraindications? Infants and elderly susceptible to the respiratory depression actions mainly, especially patients having COPD, respiratory insufficiency, emphysema, pulmonary fibrosis, they are quite prone to having this morphine acute poisoning. Bronchial asthma, morphine can precipitate attack of asthma because of its bronchoconstriction due to histamine releasing action. Hypotensive states and hypovolemia, there is exaggerated fall in BP due to morphine. So already patients having hypotension or hypovolemia due to some other reason, we should not give morphine because it can aggravate the hypotension due to depression of the vasomotor center. So these are the relatively contraindications of the morphine: infants, respiratory insufficiency, bronchial asthma, hypotensive states, and hypovolemia. Head injury is a very commonly asked question. So commonly asked question from this topic so far: why morphine is if whatever the root of morphine, why gastric lavage is indicated. Second question, important question: explain why morphine is contraindicated in head injury. Reason is actually, broadly we can say that morphine actually prevents us to assess what is the uh, prognosis of the head injury patients, because morphine and head injury often having some common features. Morphine causes head injury, CO2 retention. Head injury also causes CO2 retention. So due to CO2 retention, there is increased intracranial tension, which will add to that caused by head injury itself. There is marked respiratory depression in these patients, and there is vomiting, meiosis, and altered mentation produced by the morphine, which interfere with the assessment of the progressive head injury cases. So often we are in difficulty to assess what is the prognosis of the patient. So vomiting, meiosis, altered mentation, that is caused by morphine as well as head injury. There is marked respiratory depression due to both head injury as well as morphine, and CO2 retention due to morphine will aggravate the intracranial pressure, and intracranial pressure is already high in the head injury patient. So due to these reasons, morphine is absolutely contraindicated in head injury patients. And undiagnosed abdominal pain we have discussed yesterday, because morphine increases the intrabiliary pressure due to constriction of the sphincter of OD. So that can aggravate the biliary colic. Also it can aggravate the diverticulitis, pancreatitis. Inflamed appendix may rupture. So these are the reasons for which morphine is contraindicated in acute undiagnosed abdominal pain. So if abdominal pain is due to this biliary colic, pancreatitis, appendicitis, then morphine can be dangerous. But pentazocine, buprenorphine, other opioids are less likely to aggravate this biliary spasm. Elderly male, chance of urinary retention, because it increases the tone of detrusor as well as sphincter, so there is decreased urinary clearance, especially problematic for the patients who are having enlarged prostate. Hypothyroidism, liver and kidney disease, because morphine metabolism is slow and elimination is slow, that's why it can have some adverse effects. So these are the contraindication of morphine, remember. So most commonly you should remember bronchial asthma, COPD, respiratory insufficiency patient, elderly neonate, and undiagnosed acute abdominal pain, head injury, elderly male, and of course we have to remember that it is contraindicated in labor because it delays the labor. So drug interactions: phenothiazine, tricyclic antidepressants, MAO inhibitors, amphetamine, neostigmine, they potentiate the actions of opioids, and it retards the absorption of many orally administered drugs by delaying gastric emptying. So tricyclic antidepressants, MAO inhibitors, amphetamine, they are increasing the they potentiate the action of opioid because they decrease the norepinephrine uptake and metabolism. And norepinephrine, if you remember, this excess norepinephrine release from the medulla to spinal cord, they are actually stimulating the descending pathway, and that prevents the ascending pathway pain transmission. So opioid activity is enhanced by these drugs. Neostigmine, they are cholinergic drug, but neostigmine excess also can cause bronchoconstriction, increased due to M3 effect, and also it causes meiosis. So actually neostigmine by other mechanism potentiate the actions of the opioid. Now classification of opioids. So there are natural and semi-synthetic and synthetic. So natural opioids are morphine, codeine. Semi-synthetic opiates are diacetyl morphine and folcotin. Diacetyl morphine also called heroin, and others like oxymorphone, hydrocodone, oxycodone. They are not available in India. Synthetic opioids important are pethidine, fentanyl, methadone, tramadol, and fentanyl. And in books you will have all the drugs, description all the drugs, but you need to remember something about the morphine, codeine, heroin, pethidine, methadone, fentanyl, tramadol. This much is sufficient for your examination purpose. Now codeine I shall not discuss in detail. So what is this basic difference of codeine with morphine? Codeine is actually chemically methyl morphine, less potent than morphine, 1/10 as analgesic. So 10th time dose of codeine is required to produce the analgesia of 1 dose of morphine. Less efficacious, it's partial agonist actually, but it is mainly utilized as cough suppressant, antitussive agent, and sub-analgesic dose suppress the cough. Constipation is a predominant side effect, so also codeine can be used to treat the diarrhea. Heroin, it is not used as a drug but used as a thing of abuse. It is about 3 times more potent than the morphine, more lipid soluble, enters brain more rapidly, and that's why it's much quicker onset of action, and that's why it's caused more euphoria, especially in the IV injection. That's why it is highly addicting and favored in illicit drug trafficking. So diacetyl morphine or heroin is not used therapeutically, but it is actually a drug of abuse, and because of its highly potent euphoric action. Pethidine, it is an atropine substitute. So atropine, if you remember, it is an anticholinergic drug. So what is the difference with morphine? Once again, dose to dose 1/10 potency, just like codeine. Onset of action is more rapid, duration is shorter, not an effective cough suppressant. Spasmodic action on muscle is less marked. That's the advantage of pethidine. That's why it can be used in biliary colic or appendicitis. Meiosis, constipation, and urinary retention are less prominent, so can be used in elderly. Pethidine is believed to cause less biliary spasm. Okay, and tachycardia, due to its anti-muscarinic action, occurs instead of bradycardia. So normally morphine depresses the vasomotor center, that's why it causes bradycardia, but tachycardia is exhibited by the pethidine because of its anti-muscarinic action. Okay, and as it causes tachycardia, what should be the status of pethidine in myocardial infarction patient? In myocardial infarction patient, morphine is preferred because it not only relieves the pain but also due to bradycardia and low cardiac contractility, it causes less oxygen demand. But as pethidine causes tachycardia, so there is excess oxygen demand, so preferably should not be used in myocardial infarction. It causes less histamine release, so less safer in asthmatics, and tolerance develops slowly with pethidine due to shorter duration of action, and withdrawal symptoms develop more rapidly. So it is actually a general rule. Tolerance, as pethidine has shorter duration of action, tolerance develops slowly, because for tolerance to develop rapidly, you need to occupy the receptor by the agonist for longer time. As receptor occupancy by the pethidine is shorter, so tolerance also develops later. Okay, but withdrawal symptoms develop more rapidly. So shorter onset of action, shorter duration of action of agonist means tolerance will develop slowly, but withdrawal symptom will develop more rapidly. And autonomic disturbance are less marked during pethidine withdrawal. So pethidine is safer in many patients, like asthmatic patients, like patients of benign prostatic hyperplasia, patients of undiagnosed abdominal pain, but it should not be used in treatment of myocardial infarction. Well absorbed it is, and it is nearly completely metabolized in liver. There is a metabolite called norpethidine, which is toxic, equally sedative and euphoriant, has similar abuse potential and respiratory depression like morphine. So side effects, once again same like morphine, sedation and respiratory depression, and due to its norpethidine, that is a metabolite, it has some neuroexcitatory effect like tremors, mydriasis, hyperreflexia, delirium, myoclonus, and convulsion. And norpethidine accumulation is higher in renal failure patients. That's why we should avoid repeated dose of pethidine in renal failure patients. Okay, non-selective MAO inhibitors interfere with the hydrolysis of pethidine, so norpethidine is produced in excess. So once again, pethidine and MAO inhibitors, non-selective MAO inhibitors, should not be given together because of accumulation of norpethidine, which has some excitatory effect like hyperreflexia, delirium, myoclonus, and convulsion. So what is the therapeutic use? As an analgesic, can be used substitute of morphine. Pre-anesthetic medication we can use to control shivering. This is the specific use of pethidine during recovery from anesthesia or after IV infusion. So after recovery of anesthesia, after general anesthesia due to any surgery, or after even when large amount of IV fluid is given to treat shock, patient often complains of shivering, and this shivering can be treated by pethidine, because pethidine lowers the threshold temperature of shivering. That means patient, when at which temperature they shiver, pethidine further lowers the temperature of shivering. That's why patient is do not shiver in the room temperature. It is a preferred opioid analgesic during labor. That is an advantage over morphine. So in acute analgesic dose, neonatal respiratory depression is less marked. So these are the uses of pethidine. Fentanyl, we have discussed it in general anesthetic. It can be used as IV anesthetic. It is a pethidine container and it is more potent than the morphine, 80 to 100 times more potent than the morphine. So pethidine, codeine, they are less potent, but fentanyl is much more potent than the morphine, and it is produces few cardiovascular effects, little propensity to cause histamine, enters brain rapidly and produces peak analgesia in 5 minutes after injection, and injectable form is used in anesthesia. Transdermal fentanyl used in cancer or other types of chronic cancer pain. Now, this is methadone. So it is a very unique analgesic. It has a very long duration of action, and but advantage is that it do not cause euphoria. That is therapeutically utilized in treatment of morphine addiction. It is synthetic. Analgesic, respiratory depressant, emetic, antitussive action, biliary effect are similar to morphine. So, and it has high oral to parenteral activity ratio. It is firmly bound to tissue proteins, and also receptor occupancy, like mu opioid receptor agonist, its receptor occupancy is longer, and it is cumulative in nature on repeated administration, unlike morphine. Plasma THF on chronic use is 24 to 36 hours. So look here. So plasma THF is long, it is cumulative and firmly bound to tissue proteins, and also occupy the receptor for longer time, and it has slow persistent nature of action. So that's why if suppose a patient is on morphine, chronically abusing patient, morphine is patient taken by any means for longer time, if methadone is given, methadone will occupy the mu receptor or other receptors for longer time, and as it do not cause pleasurable effect or euphoria, then morphine, even after patient is giving methadone, if morphine is taken, then morphine is not taken up by the receptor is already occupied by the methadone, then morphine is not effective, morphine cannot produce euphoria in them. That's why patients will not feel any pleasure which he was obtaining after using morphine. But after using the methadone and morphine together, as methadone is occupying the receptor for longer time, morphine is not producing any effect. That's why pleasurable effect or euphoria is less. That's why patient is not getting the effect for which morphine he was taking the morphine. That's why it can be used in treatment of the addiction. So abuse potential is low with methadone, and sedative and subjective effects are also less intense. So therapeutic use as substitution therapy or opioid dependence, 1 milligram oral methadone can be substituted for 4 milligram morphine or 2 milligram of heroin. So methadone as maintenance therapy in opioid addicts is used. Sufficient dose of methadone is given orally to produce high degree of tolerance. So methadone is used orally, and if it is given in higher dose, it can produce high degree of tolerance, and also receptor occupancy is longer. That's why morphine, even if taken by the patient after giving methadone, it will not produce any effect. It will not produce any euphoric effect. That's why patient will feel less urge to take repeated morphine. So pleasurable effect of every dose of morphine or heroin is not perceived. It can also be used as an analgesic, but mainly methadone is used in treatment of the opioid addicts. Tramadol, a very commonly used analgesic, can be used orally as well as IV. Apart from its opioid-like analgesic action, it inhibits the reuptake of the norepinephrine and 5-HT. So if you remember the pain pathway once again, so NE and 5-HT excess release from the medulla to spinal cord, they are actually decrease the excitability of the dorsal horn and prevents the pain transmission by the ascending pathway. So tramadol inhibits the reuptake of the NA5-HT, so there is excess NA and 5-HT in the system, and this activates the monoaminergic spinal inhibition of the pain. So there is further decreased excitability of the dorsal horn, further decreased pain transmission in the ascending pathway. Analgesic action is only partially reversed by the naloxone. Analgesic potency is 1/10 of the morphine, and the THF is 5 hours. Effects last for 4 to 6 hours. Less respiratory depression, sedation, constipation, urinary retention, and biliary spasm are less. So just like pethidine, it can be used in treatment of can be used, actually it should not be used, but it can be used in treatment of biliary spasm, urinary retention, and constipation. TF is 5 hours. Effect lasts for 4 to 6 hours. Indicated for mild to moderate short lasting pain, especially chronic pain including cancer pain, injury, post-operative. And tapentadol is newer drugs, like action is same like tramadol, negligible effect on serotonin reuptake, More potent than the tramadol, doesn't rely on metabolism for its therapeutic effect. Useful for chronic musculoskeletal pain, post-surgical pain, pain in diabetic neuropathy.